Good evening, everybody, and welcome, and thank you for joining us for tonight's meeting on rheumatology and joint pain in partnership with St Vincent's Clinic and St Vincent's Private Hospital. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us today. I would now like to introduce the two CEOs of St Vincent's Clinic and St Vincent's Private Hospital. So we have Heidi Bayliss, who is the CEO at St Vincent's Private Hospital, and Katie Viviers, sorry if I said that wrong, who is the CEO of St Vincent's Clinic. So welcome.
Thanks, Bertha, and welcome to everyone tonight. My name is Heidi Bayliss, and I'm thrilled to be welcoming you to our latest GP education webinar, Rheumatology and Joint Pain. And as the new CEO of St Vincent's Private Hospital and St Vincent's Private Community Hospital in Griffith, I've worked in both public and private hospitals for over 30 years, and most recently I was the CEO at the Mater Hospital, and I feel very privileged now to be leading these two hospitals. Patient-centred care is at the heart of what we do, and I'm committed to working with our staff, doctors, community, and you, our GP referring community, to ensure we meet the unique needs of our patients. Tonight, I'm very pleased to be introducing you to two of our leading orthopaedic surgeons. Associate Professor Nick Forsyth is an orthopaedic surgeon specialising in joint replacement of the hip and knee. And as chairman of the Department of Orthopaedics at St Vincent's Private Hospital, Sydney, he is a leader in his field, placing particular importance on precision medicine and championing minimally invasive surgical techniques. Associate Professor Forsyth has a fellowship in hip and knee arthroplasty surgery from Harvard University. Dr. Tim Yeo is a shoulder and knee orthopaedic surgeon, and together with his patients, Dr. Yeo is committed to providing the highest level of care through expert knowledge, compassion, and technically advanced techniques. His ongoing research allows him to use the most up-to-date and accurate surgical techniques to benefit his patients. Tonight, they will discuss the assessment and management of common hip, knee, and shoulder complaints, including tailoring care plans to patient needs. Thank you for joining us, and I look forward to connecting and working with you and your practice through our ongoing GP engagement program this year.
Hi, thanks Heidi. My name is Katie Viviers. I'm the CEO of St Vincent's Clinic, and I'm delighted to join Heidi this evening in welcoming you to this interactive webinar in collaboration with the Central and Eastern PHN. St Vincent's Clinic is a multidisciplinary clinic of excellence with over 300 specialists practicing across around 30 healthcare areas. And we provide a comprehensive range of investigative, diagnostic and therapeutic services for patients referred to for healthcare. The clinic's also the home to St Vincent's Clinic Foundation, which funds research across the Darlinghurst campus, and Open Support, which is a community-based organisation providing support to women and children escaping domestic and family violence, as well as individuals across the community experiencing social isolation. And tonight, in this webinar, you'll hear from two of our orthopaedic surgeons, as introduced to you by Heidi, but also from two of our rheumatologists. Now, Dr. Leila Gerges is a rheumatologist with particular interest in rheumatoid arthritis, inflammatory rheumatic diseases, biological therapy, and general rheumatology. She is the head of Department of Rheumatology at St Vincent's Clinic, and along with her clinical work, Dr. Gerges teaches undergraduate students, trainees, and senior resident medical officers, as well as maintaining her research interests. Also on our panel tonight is Dr. Malcolm Handel. Dr. Handel is a rheumatologist with particular interest in inflammatory arthritis and biological therapy. His research activities included pathology of synovitis, mechanisms of drug action, and clinical drug development. He has worked across academia and industry, including as Director of Immunological Medical Affairs for Johnson & Johnson Asia Pacific. These days, he runs a clinical rheumatology practice and teaches students at St Vincent's Clinic in Sydney. Tonight, they will discuss the assessment and management of acute inflammatory arthritis, including tailored care plans to meet patient needs. Thank you again for joining us. I look forward to connecting and working with you in your practice through our ongoing engagement program. Thank you.
So good evening and welcome. everyone, and thank you for joining us this evening for this talk. So I'll be speaking about inflammatory arthritis, a case study in diagnosis and management. And I've put together some learning outcomes, which I've subdivided into two groups. The first learning outcome relates to acute inflammatory arthritis presentations. And the outcomes will be to describe how to distinguish inflammatory from mechanical symptoms, how to identify symptoms that require a specialist referral for diagnosis or assisting in diagnosis, and to implement a timely care pathway for acute inflammatory arthritis. There is a second outcome with regard to the long-term management of inflammatory arthritis patients. And this involves identifying any symptoms or changes that require specialist referral for any updated management questions, and to recall patients to assist them with long-term management support. These outcomes will be covered by the first case, and then there'll be a second case which I'll just send to you as a resource after the talk in order to save time during this evening. So case study 1 with the first is particularly focused on the first learning outcomes. And this involves Mrs. SC, who is a 46-year-old married lady living in the eastern suburbs. She described a palindromic onset of joint pain and swelling occurring for around 1 year. The pain initially occurred in the right shoulder for a couple of days, and she thought it was some sort of a physical strain. It subsequently affected the left shoulder and then the right wrist, joints in both hands, and later the feet. The pattern was of spontaneous resolution over a 2 to 5 day period, and then moving to another joint, perhaps after some weeks. She tended to shrug this off and actually didn't mention it to her GP during visits there for other things. Eventually, after about 1.5 years of this pattern, she started to develop persistent joint swelling and pain. It was most particular or noticeable to her in her hands and feet, but she felt pain and stiffness all over in many joints, making her feel old. She described early morning stiffness and fatigue. At that stage, she actually did mention it to her GP during a visit there for something else. She had difficulty mobilising. She described difficulty with all her household chores and caring for her family, and she stopped working in the family business. She did not have fevers, sweats, or systemic symptoms. And prior to this, she had been completely fit and well. She had no relevant background history. On examination, and I've taken the examination when I first saw her, she had swelling and tenderness in all of the MCP and PIP joints of both hands. The photograph shows a sort of shiny skin and mild swelling and no actual deformities. She had tenderness in the elbows, shoulders, knees, ankles, and the MTP joints in both feet. There were no skin changes apart from this slightly shiny appearance in her hands. She had no nodules. She had a normal spinal examination with normal range of movement. The heart sounds, chest, and abdominal examinations were normal. So in summary, she actually demonstrates a symmetric peripheral inflammatory arthritis. It had been present for more than well over 3 months from the time of onset to the time when I saw her. She had no features of infection and no spinal symptoms. Helpfully, her GP had actually arranged some initial investigations before sending her along for the consult. Her full blood count and biochemistry were normal. She did have elevated inflammatory markers. The rheumatoid factor and CCP were both checked. And although she was rheumatoid factor negative, she has a positive CCP in a moderate, not very high, but moderate level. She did have an X-ray of her hands, and you can see that although she has no erosions, no deformity, good alignment in all the joints, but looking from a distance, you can see a juxta-articular osteopenia that is often spoken about. So if we look particularly around the MCP joints, you can see that the bone cortex looks a little thinner and the bone looks less dense there. And this is assumed to be due to the cytokine milieu when there is prominent inflammation. She had already had an MRI scan of one hand. She had tried 2 different non-steroidals with no benefit by the time she had attended my clinic. I would like to show here that the ultrasound of the joints is a very helpful tool for us. As you can see that on ultrasound, fluid shows up very easily. The fluid is anechoic and therefore shows black like a bubble. So on the right, you can see a tendon in cross-section and you can easily make out the effusion around the tendon. And on the left, you can see fluid over the joint. So the hard white line on an ultrasound is usually a bony surface and you can see fluid over the joint. She also had an MRI scan, and I should confess that this is not actually her MRI scan, but I've selected this picture as it demonstrates what I'd like to demonstrate a bit more clearly. So on MRI scan, we can observe a lot of differences that may not show up on ultrasound or plain X-ray, mainly because of the planar nature, the 2D nature of the X-ray shows the carpal bones overlapping, and therefore these small erosions may not be visible until you get the actual detailed sections of the MRI. This T1 weighted image is showing early erosions, of which she had some, and synovial thickening and some joint effusion. So this is obviously helpful to the diagnosis. Now, interestingly, the patient herself had comments and questions when she came to the first consultation. She said, "I'm hoping that you will say it is not rheumatoid arthritis because I don't have rheumatoid factor. What do I have? How can I be treated? Will I return to normal function and daily activities? What will happen as I get older?" So these are fairly typical of the patient's concerns, and I'm sure that you all as GPs are faced by the patients asking these things at a regular, on a regular basis. So the discussion went along the lines of explaining that she does have an inflammatory arthritis of her peripheral joints, and that although the clinical examination could narrow down the differential diagnosis, the fact that she had an inflammatory arthritis for more than 3 months makes it less likely to spontaneously resolve, and that the further investigations and assessment are to confirm the precise diagnosis, to rule out any overlap syndromes, and to prepare her for an appropriate disease-modifying therapy aimed at improving her outcome in regard to the questions that she had asked. So the goals which were discussed basically are to establish the diagnosis and then to institute effective management to control synovitis, which will have the ultimate goal that we want of preventing long-term damage, therefore preventing erosion which leads to deformity, and restoring her quality of life, which is what's important to her, no pain and having normal daily function, and reducing or managing comorbidities. And finally, along with all this, educating the patient empowers her to actually manage her condition. So the initial management included prednisolone 10 milligrams daily, commenced whilst further investigations were arranged. A wider immune screen was performed, and she was found to have a positive ANA at a low level of 80 homogeneous pattern, but negative double-stranded DNA and ENA. Her immunoglobulins were normal, her MSU was clear, chest X-ray was clear, lipids, vitamin D, iron, blood sugar were normal, and an infection screen was also performed. She was then seen again and given a diagnosis of rheumatoid arthritis, which is CCP positive and erosive in an early stage. At that time, she was ready to take on board the discussion about commencing methotrexate with the aim of controlling synovitis, as we mentioned, stopping her pain and also preventing any deformity and limitation occurring in future. She was advised of the routine monitoring blood tests that would be required and the treat to target principle, which involves review regularly and adjusting therapy until the goal of a clinical remission is maintained, and then maintaining this with less frequent follow-up. So she received support and education in order to feel that she's at the centre of the team, and her GP was vital in being part of this team, helping her to coordinate her care, to follow up and reduce any comorbidities, particularly with regard to blood sugar, cardiovascular risk, lipids, blood pressure, so all of the factors that you would be familiar with, to help her with age-appropriate screening on account of her immune suppression, such as skin checks, mammogram, when appropriate vaccinations, checking her bone density. The GP also helped her with referrals to allied health. She chose exercise physiologist as well as nutritional support. And the rheumatologist's role is to really review her progress and adjust the disease-modifying therapy to reach our goal. So the allied health, as I mentioned, included exercise physiology, hydrotherapy, good nutrition, podiatry, and education, including reading reputable sources or listening to webinars such as the Arthritis Australia webinar. So we come back to then our summary points about the learning outcomes. So the first outcome was to describe how to distinguish inflammatory from mechanical symptoms, which I think you would have picked up from this case with regard to the morning stiffness, the swelling, the inflammatory markers, and I'm sure you've all seen these sort of cases. The second was to identify symptoms that require specialist referral for diagnosis. So in this case, she had new symptoms that were persistent, more than 6 weeks, and not resolving. She had an undiagnosed inflammatory disease, so it's appropriate to confirm the diagnosis and then also to institute a management plan. And to institute a timely care pathway. So it was actually very helpful that her GP recognised the symptoms and assisted her by arranging appropriate initial tests, simple treatment with the non-steroidals, initiating the referral, and we'd like, where possible, to be able to assist you with the early implementation of assessment and treatment. So refer early. It's been shown in some studies that, for example, delaying commencement of an effective DMARD by 3 months can result in greater erosions and deformity at 5 years. So I'll stop now to take questions, any questions or comments about the case. Thank you.
Dr. Gerges. We did have a question which I believe Dr. Handel has answered, but I don't know if you wanted to add anything else.
So we think that methotrexate cough and interstitial lung infiltrate is more likely to be an idiosyncratic reaction, something that is not common and tends to occur probably within the first 6 months of therapy if it's going to occur. For the case of patients who have already, sometimes this comes up in patients who already have an interstitial lung disease and there's concerns about should they get methotrexate or not. Overall, we think that actually the risks of methotrexate are quite low, and if it reduces inflammatory rheumatic disease, it'll probably improve the outcome. But the chest X-ray before starting treatment is quite useful as infection screening, as well as screening for any unidentified lung disease.
Okay, great, thank you.
Does celasophyrene have any role in patients to help manage their rheumatoid arthritis?
Thank you, Nick. Thank you, Dr. Asawa. So yes, there are a variety of disease-modifying agents, and I think that's important and that we shouldn't forget that. So although methotrexate is often chosen, mainly because it has the best data for showing prevention of erosions, and therefore you reduce the joint space narrowing and deformities in the long run. But we've got to remember that some patients are intolerant of methotrexate, or they may be are just not willing to take it. If they don't have erosive disease, they may not need it, and not all the patients have erosive disease. The ones who have high-level rheumatoid factor and CCP, we now refer to as double positives. So the double positives are more likely to have erosive disease and probably need the more potent DMARDs. For patients with mild disease with no evidence of erosions, they can certainly try celasophyrene or hydroxychloroquine or combinations. And if patients have a side effect to methotrexate, then they should also try other disease-modifying agents. And so I think it's very important to tailor the therapy to the patient, and that will be discussed with them at their reviews. And also the GP is often central in this because they might tell you how they feel about it or any side effects or what's worrying them before they come back for their review. So, you know, if you want to flag something and send us a note about it, or it's really ideal to tailor to the patient.
Great, thank you, Dr. Gerges.
Okay, well, it's a pleasure to talk to you all this evening. I want to highlight one particular aspect that occurs in inflammatory arthritis called enthesitis. And the reason I want to emphasize it is because it's something that's often not taught to the medical students, and it's possible to get into clinical practice without really having it highlighted as a feature of inflammatory disease. And I'm doing this in the context of psoriatic arthritis because it's in psoriatic arthritis where we see a lot of enthesitis, but not exclusively so. So the learning outcomes for today include issues to do with both diagnosis and the management of psoriatic arthritis. I've put 4 learning outcomes here. The first, I think, is very important, and that is that in order to make a diagnosis, or more diagnoses, if you like, of psoriatic arthritis, you need a high index of suspicion. You really do have to look for it. Enthisitis, which I'll show you in a moment if it's not familiar to you, is a fundamental feature, and you have to look for it and look hard. With regard to the psoriasis, it's the psoriatic nails or hairline psoriasis that can be subtle, but these are the strongest predictors of psoriatic arthritis, not necessarily the plaque psoriasis. And the other important learning outcome from a diagnostic point of view is that unlike the patient that Layla just presented to us with high inflammatory markers in rheumatoid arthritis, quite a few of the patients that we see with psoriatic arthritis have only moderate or mild elevation of the inflammatory markers. So the issues to do with management that I think make good learning outcomes are to start conventional synthetic disease modifying drugs as soon as possible. And you've seen Layla highlight that in the rheumatoid case that she presented. Doing this as a shared care plan between the rheumatologist and the general practitioner, I think is definitely in the patient's interests and helps communication. And I strongly support that shared care model. If a patient does present with an inflammatory type arthritis of this sort, I think it's always good to prepare them as soon as possible. And this can be done in the general practice. Just as Layla showed, we always exclude latent tuberculosis with both a chest X-ray and quantiferon. That's because of the possibility of using biologic therapies later, but it's good to get that one done soon. And I think immunizations to be updated, and different people have different immunization needs, but to get that updated as soon as possible before they start other drugs, I think is a high priority. And I encourage everyone in general practice to really be on top of that in these patients with inflammatory diseases. And if they are going to get a biologic drug, which is often the case, from a point of view of the pharmaceutical benefit scheme, they need two of the traditional drugs. They're methotrexate, leflunomide, or sulfasalazine. You need two of the three. Steroids need to be minimized. They have significant side effects. They should only ever be seen as temporary. And it's really quite important to keep patients as physically active as you possibly can. So they're the learning objectives for this case. So there's very quickly, I'll do a case presentation of one particular case. This is a real case. It's a 27-year-old man. He was an electrician when he first came to see me. He was unable to work because of nocturnal back pain, ankle pain, foot pain. He had seen a dermatologist. He had psoriasis. It was fairly mild. He was just using shampoos for that. And on physical examination, you could see the scalp psoriasis, but it was fairly minor. It was along the hairline. He also had nail pitting, which is a very important physical sign, and he hadn't noticed it himself. And from a joint point of view, he had quite obvious right Achilles tendinitis and inflammation of the ankle joint and possibly also the subtalar joint. I'll show you a photograph of that in a moment. He had dactylitis of the second left toe, and I'll show you a photograph of the dactylitis. So he had some investigations, and the CRP 8.3, that's a bit elevated, especially for a 27-year-old man, but certainly not dramatic, and just an ordinary virus would be enough to do that. ESR7, HLA-B27 was negative despite his lower back pain, and I think he probably did have some sacroiliitis. Serology for rheumatoid arthritis was negative. X-rays were normal except for the soft tissue swelling, and X-rays of the sacroiliac joints were normal. So there wasn't a lot to see except for the Achilles tendinitis and the dactylitis. This is a photograph of that man, this young man. You can see, I don't know if you can see my cursor, but I'm encircling the swelling where the Achilles tendon inserts into the posterior part of the calcaneus. Achilles tendinitis is not always as obvious as this. Sometimes it's just tenderness. And there's a general swelling around the ankle joint and probably the subtalar joint as well. So just a brief slide on Enthisitis. The left side shows Enthisitis, which occurs in spondyloarthritis. Enthisitis, by definition, is where inflammation occurs at the site of insertion of a tendon or ligament into bone. So this is obviously a tendon. That could be a ligament on the top. If there was inflammation at that insertion site, we call that enthisitis. This is in contrast to synovitis, shown in the diagram on the right, which is more common in rheumatoid arthritis, and that's the swelling of the tissue around the joint itself. Rheumatoid arthritis does not typically cause enthisitis. It's mainly in the spondyloarthritis group of diseases, including psoriatic arthritis. So this is back to our young electrician. He has dactylitis. This is swelling with pain, redness often, and usually exquisitely tender, of often just one toe. It's quite asymmetric. It may have been triggered just by stubbing his toe, minor trauma, and this persistent inflammation. And it's quite characteristic in psoriatic arthritis and other types of spondyloarthritis. This is a textbook diagram showing all these red dots where tendons and ligaments and the trochlea attach onto bone and other connective tissue in a digit. And there are lots of red dots here. The assumption is that dactylitis, as you can see here in this fourth toe in this picture, that dactylitis is probably a coalescence of enthisitis at all these multiple spots. That's more theory than practice, but that's the way I choose to think about it. We mentioned that the presence of psoriasis of the nails, which you see here in this extreme textbook example, is something that correlates very highly with the presence of joint disease. And there's a theory behind this too. So here you see a distal interphalangeal joint with an extensor tendon that can insert into the bone. That would be enthisitis, but it also, the tendon inserts into the proximal end of the nail plate, causing abnormal nails. So we can think of the abnormal nail in psoriasis as being a kind of enthisitis of sorts. And it kind of explains why the presence of nail abnormalities correlates so strongly with the presence of joint abnormalities. So in my practice, I keep some 3-diopter glasses so I can see the pitting in the nails, because it can be quite subtle, as it was in the man that we presented. This is again a textbook example, not the man that I presented, just showing sacroiliitis on a plain X-ray. The point here is that it's very subjective. 3 different people will give 5 different opinions about these sacroiliac joints. So it's subjective. It's not a concrete thing, but do look for it. And just like much of what we see in psoriatic arthritis, it's very much a clinical diagnosis. You can't do it by the numbers. So the management of the case that I presented, our 27-year-old electrician who's now 30-something. In 2019, he started leflunomide as a disease-modifying drug. The following month, I added methotrexate. He was improving, but he still couldn't work. Had some prednisone temporarily, but only ever temporarily. And the idea was maybe step up to biologic drugs. So he was prepared for that possibility with the exclusion of latent tuberculosis. And in May 2029, he started one of the TNF antagonists, and we've got several to pick from. And he did very well. I kept the methotrexate going because it works well in combination with golimumab. The leflunomide was ceased because of liver function tests. He had an excellent response. And the interesting thing is that fatigue, which had been a dominant symptom, resolved. So a lot of this is about function, and his function was good. He returned to full-time work. Unfortunately, it's not always plain sailing with an easy follow-up. In May last year, he relapsed. His left ankle was swollen, it was painful, was interfering with his work, he couldn't climb a ladder properly, but his C-reactive protein was still normal. Anyway, we did a cortisone injection to the left ankle. That, of course, is a temporary measure. It's not a long-term solution to his problem, but we switched his biologic. In this case, I went to the IL-23 antagonist, guselkumab, but I could have switched him to another TNF. I could have switched him to an IL-17. There are lots of options with the biologics here. He gradually improved, and I last saw him in January, and he was doing very well and working full time. So it's a good outcome for him. So the learning outcomes from this case and for psoriatic arthritis generally are, first of all, you need a high index of suspicion to reveal the hidden cases. Enthisitis is a fundamental feature that must be sought. Look hard for it. It can occur all sorts of places in the body. Psoriatic nails and hairline psoriasis can be subtle, but strongly predict the possibility of psoriatic arthritis. And inflammatory markers are not always high, although the worst cases, of course, do have high inflammatory markers. From a management point of view, just as Layla said, for the rheumatoid patients, we want to start disease-modifying anti-rheumatic drugs early, and shared care between the general practitioner and the rheumatologist is really the optimum way to go about doing this. We prepare the patient for treatment with conventional synthetic drugs, and in case they fail, prepare them for the possibility of biologics. So we look for the TB, really think about getting the vaccinations up to date, and for the older people, that's often to do with shingles vaccine. And the modern Shingrix vaccination is not a live attenuated virus, unlike the Zostavax, which was. The patient needs to have been exposed to 2 of the traditional modifying drugs to get a biologic. And we want to minimize the use of corticosteroids, only ever use them as a way of buying time. And my last point is keep the patient as physically active as possible. There's a lot of value in being physically active. So those are the learning outcomes from today, and I'm very happy to take questions.
So thank you very much for your presentation.
Excellent, thank you.
Thank you, Malcolm. That was a fantastic talk, and I want to thank Layla as well, because certainly my understanding of biologics has been pretty basic, so I've learned a lot tonight. My brief tonight is to try and give a bit of an update about where we're going in precision medicine, particularly in arthroplasty, because that's my subspecialty. There we go. So, you know, this is a picture of basically what we see in orthopedics, which is our bread and butter, osteoarthritis. You can see the joint space narrowing, the bone-on-bone articulation, and the deformity, the secondary deformity that comes on. So that's basically most of the patients we see. We see patients from our rheumatological colleagues, of course. We see a lot of post-traumatic arthritis these days. So these are patients who previously had a cruciate reconstruction many years ago, and then go on to post-traumatic osteoarthritis. And this is our goal, you know, to give them a well-aligned, well-fixed, well-balanced knee replacement. And we could go into, you know, the finer details of sizing and balance and alignment, which are very important factors, and that's where we're moving into these days. In hips, similar sort of story. We see a lot of osteoarthritis, secondary osteoarthritis. This is someone who was born with a dysplastic hip. You can see their left hip, the acetabulum's not formed correctly, and the hip's basically dislocated. That's a very challenging hip replacement. This is avascular necrosis. You can see in that left hip where the articulating, the femoral head, you know, the most part of it, of the articulating or weight-bearing surface has collapsed, and that segment is actually avascular, if you can see my arrow. So this is what rheumatoid arthritis looks like. It's quite different to osteoarthritis, where you get this symmetrical joint destruction. secondary to the synovitis that Malcolm so beautifully showed in that slide. And this is our goal, once again, to give a well-aligned arthroplasty, which is, well fixed and down the middle of the bone, so we can get an arthroplasty that works well for a long time. Now, things don't always go well. Patients fall over and have fractures, and I just want to show you what this means to the patient. It's a big deal to fix something like that, where a stem is loose and it's fractured, where the revision surgery is quite extensive. So these are sort of the things that we're trying to avoid these days, revision surgery. So we're talking about why things fail, why do knees fail? And, the main cause is loosening or lysis, secondary to wear. Infection is our second biggest cause of revision. Tibial polyethylene wear, pain, and patellofemoral pain, usually when the patella hasn't been resurfaced. Now, infection is an absolute disaster in arthroplasty. This is, a patient who's basically had knee replacement and everything has, the infection has broken through the skin, and this is a major problem to deal with. And this is what it looks like to treat an infection. This is a spacer. So this is a cement-loaded antibiotic spacer, which we've put into the knee. In the interim, what we most commonly do, which is what we call a two-stage revision, where we take everything out and we put this cement-loaded articulating spacers. This is the basic, not the basic, but the latest type of spacer where the patient can actually walk on this. And that's in for usually at least 6 weeks till their inflammatory markers come back to normal. The skin is absolutely healed and the patient feels well. There are different options, like this is a fusion of the knee. But there's different ways to fuse a knee. Like that's if we've failed in terms of managing our infection. This is sort of an end stage thing. So this is an intramedullary nail. We can use an external fixator, or we can use double plating techniques. But these are the sort of things we want to avoid. This is a hip spacer. This is what a hip spacer looks like. So that's an antibiotic loaded spacer. And that's a girdle stitch. That's when infection, we've got a multi-resistant bacterium. We haven't been able to manage the infection, so we just take everything out and leave it out. And this is what we want to avoid. We want to avoid complex revisions. This is one of my patients where this is a custom-made prosthesis, 3D printed, and this is the latest technology where we do a CT scan preoperatively, and this implant is actually made to fit all the bony defects and makes a complex revision just a little bit more straightforward. I want to talk a little bit about wear. So this is what worn arthroplasties look like. So at the joint space, you get basically wear of the polyethylene. You can see here, where the polyethylene, this is actually where the locking mechanism has failed. And that leads to polyethylene debris and wear and what we call osteolysis. So what happens is the articulating surface starts to wear. You get polyethylene particles pumped in behind the acetabulum, and you get this osteolysis. Now, what that looks like on X-ray is this. See this massive osteolytic lesion behind the screw hole in the acetabulum? That's where the bone has been eaten away by the osteoclasts, or the macrophages, and where they form these giant cell granulomas and just basically destroys the bone. And then we moved on to, I want to move on to, this is a knee that's worn out. You can see that this is it's articulating through now into the metal. This is a patient of mine who'd had a knee done many, many years ago, and you can see these massive osteolytic lesions here. So, and what that looked like intraoperatively here, you can see the plastic has been worn through. He's actually been wearing through into the metal, and he's got titanium synovitis. That's what it looks like, this black synovium. And it's a really difficult problem to treat. So, and we've moved on to alternate bearings, and I think most people have heard about ceramics and ceramic on ceramic, and this is because our debris is much less, an order of magnitude less. Chronic inflammatory response goes down, and then we obviously get less osteolysis and loosening. but it's not without risk. This is ceramic. This is one of the earlier generations of ceramics. They were very, very brittle and they would fracture. So this is a hip X-ray which shows, if you look at this side, that's a metal head. This side is a ceramic head which is fractured. You can actually see part of the femoral head which is fractured off there. And that's a difficult, that's a problem, because what then happens is that it damages the trunnion of the stem and it damages the cup, and you may need to revise the whole hip. This is malalignment. This is actually a stem that's missed the femur totally. This is obviously malalignment, where the cup has actually fallen out of the pelvis. So these are all causes of revision. This cup, this is a resurfacing. That cup is almost vertical. It should be at about 40, 45 degrees. I think everyone can see that this cup's in the wrong position. It's actually in the pelvis. This is, you know, this happens, and it happens more often in different approaches. And that's the issue that we talk about, different approaches. There's a lot of hype about the anterior approach, but, you know, there's a big paper out of the UK last year saying that the risk of a periprosthetic fracture with an anterior approach is significantly increased, even in experienced hands. So it's a bit of an issue. This is once again component malalignment. That's where the cup is spun out of the pelvis. And once again, another fractured implant. But I want to move on to talk a little bit more about instability and about precision medicine. And this is an unstable hip, of course, and that can be secondary to component malalignment. If you don't put the bits in the right spot, things can dislocate. Even knees can dislocate. And this is once again component malalignment, where you can see that this tibia is pointing, the tibia is over there where it should be pointing straight down the middle. So that's a catastrophic failure. And this is what we do. We do a revision, a well-aligned implant, which is well fixed, well-aligned and well-balanced. And when we talk about balances, this space is the same as that space. So the medial space is the same as the lateral space. But, you know, even revisions have problems. This is a revision where the implant has fractured. And this man had been walking on this fractured implant for 10 years because everyone was worried about what they could do. What could they fix it? Anyway, and this is a fractured implant in a hip. This is what we want to avoid. We want to avoid, you know, catastrophic surgery. This slide I do love because it's got everything that could possibly go wrong with the hip replacement. It's got, you know, revisions, loose implants, broken plates, everything. So I know I'm running out of time, but I'll quickly want to touch on computer navigation. And this is where we're moving towards. So the real brains of precision medicine is computer navigation. So what's the goal? We want to accurately align well-fixed implant, which is well-balanced, using the best implant for our patients to basically give them long-term survival. And we can see with malalignment, you get poor function, increasing wear, loosening, and failure. So this is what a well-aligned, well-balanced, well-fixed implant looks like. Dead down the middle, beautifully sized, beautifully balanced, where that space is the same as that space. So a quick history about navigation. It all started by Ken Krakow way back in 1995. There's lots of companies that do it now. Almost all companies will provide navigation system. They can be CT based or CT free. So essentially you can either put a patient through the CT scanner, do a preoperative planning, and then you load that into the computer and you do navigation. This is what it looks like in the operating theatre. And then there's CT free, which is the system that I use, which you do all your planning in the theatre. You do, you know, your hip center, ankle center, knee center, and then you can make your plan on how you want to cut the bone. And this is what it looks like in the theatre. It precisely tells you where to cut the bone. And in patients who previously had trauma like this, we can't use conventional instruments. So navigation is a real plus. And there's MRI-based systems, but we'll move on because you know, Bertha will probably pull the plug on me in a moment. But this is what's available to surgeons now, where we can plan preoperatively the size of the implant, the alignment, the balance, and you can see down the bottom here, you have all these options of changing your plan before you come to theatre. And you can do it in multiple different ways. You can have these prefabricated blocks there, which help guide the pins for the cutting blocks. And this is what it looks like. That helps cut the bone. And then now we're moving on from these, where we've got navigation, but we sort of say, I think the important bit, I want to move on to the paper that's very important, which is basically a landmark article, which was Richard de Steiger's paper, which is this one, which was out of our joint registry, which looked at basically 44,000 joint replacements over the last 10, 20 years. And what we realized was that navigation significantly reduced the rate of revision. So everyone's moving towards navigation and robotics now. So in conclusion, what we want is a navigation system that has a minimal learning curve, that can give us accurately aligned knees, and improve our jig system and improve accuracy of decreasing out these outliers that we used to get with conventional systems. Now, what we're using robots now. We're actually, I've done ROSAs in the past at St Vincent's, so we did the first robotic persona in the world at St Vincent's. This was a couple of years ago. Now we've got the Valise robot, which is a Johnson & Johnson robot that's just arrived, and this is the Mako robot, which Tim Yeo uses as well. That's arriving in the next couple of weeks. So this is a very exciting time for us at St Vincent's. I'll stop there and take some questions. Sorry, there was a lot in it. I'm just looking at the questions. Minimally invasive surgery, are they less likely to cause complications? Well, what we say is less tissue trauma, less blood loss, less pain, faster recovery. Now, there is a flip side to that, because minimally invasive surgery can actually increase your complications because you can't see as well. So you've got to be very comfortable with a limited view, because I think it actually increases your risk of component malalignment if you're not very comfortable with minimally invasive approaches. The other question from Dr. Asaba was, do ceramic joints less likely to cause osteolysis? Absolutely. So we've shown that in comparison of ceramics to, say, metal and polyethylene, it's 100 times less wear particles. So yes, ceramics, that's why ceramics were developed, and they certainly do cause less osteolysis. There are implants made in Australia, that was by Global Orthopedics, but most of them are made overseas, over in Warsaw, Indiana. Some are made in Europe, a lot are made in Europe actually. But then I think implants are basically made worldwide now. Any other questions?
Nick, I had a question. This is Layla.
Hi, Layla.
Thank you very much for fascinating talk with a lot of very challenging cases. I just wanted to ask about the selection of size of prosthesis, because sometimes we hear of patients having issues where maybe the acetabular cup or the implant was the wrong size. Is that part of your assessment preoperatively? I mean, a part of the skill of the surgeon, or does the navigation equipment help you with this?
Yeah, yes, Layla, thank you. That's a great question. I thank you for that. It's multifactorial. So when I'm doing a joint replacement, I use this. I've got special X-rays I used before that we use cellulose overlays where we can get an idea of the size of the acetabulum or the size of the femur, and then intraoperatively, the computer will tell you also what size the implant should be. So, we've had these problems in the past when we didn't have navigation, where you had this component, the sizing was incorrect, and you can get into trouble because in the knee, if the implant's not sized correctly, it affects the balance, and the longevity of the implant. And in the hip, if you get the acetabulum wrong, it can lead to a whole lot of trouble. You can remount the acetabulum, you can lose a posterior column, you can lose an anterior column, it can lead to instability, it can lead to impingement. So it is a problem. So we do have help these days, though.
That's it for now. So thank you very much, Professor. Oh, let me see.
Pleasure. Do I get to hand over to our young gun, Tim Yeo, now?
One last question. Is computer navigation surgery available in the public hospital?
Yes. I did computer navigation to the public for well over 15 years.
Perfect. Thank
The
you.
only problem is robotic surgery is not available at the public at the moment that I know of, but we are in the process with Heidi Baylis to organise a Johnson & Johnson Research Institute at St Vincent's, which will be cross-campus, where we'll have a robot at both the public and the private to expose the registrars to robotic training as well. And that's in the pipeline. That's going to happen very soon.
Great.
And we know that our new CEO, Heidi, has a real focus on precision medicine, which is fantastic. So we've really got her support in moving forward in this way, because this has been going on for some time now, trying to get the funding, because these robots are not cheap. And now we've basically got 2 robots at least. So it's good news for us.
Sounds very exciting. Thank you very much for that presentation. And Dr. Yeo, you're lucky last.
Lucky last, and finishing off with the best joint in the body, I reckon, the shoulder. This is me, so you can find me in multiple places, but home base really is St Vincent's. At the end of today's talk, we'll be able to differentiate between arthritis and other shoulder pathology that presents very similarly. We'll be able to understand the difference between the shoulder replacement types and their advantages, and also aid our patients in achieving their post-operative goals. So I think that the shoulder, more so than any other joint in the body, is quite difficult to pinpoint where pain is coming from. You know, it can come from within the joint, for example, the cartilage or bone, from the capsule lining itself, or the labrum or biceps tendon. It can also come from outside of the joint, for example, the rotator cuff or the bursa, and it's really hard to differentiate between all of these things. As we know, for the treatment of arthritis, it can range from just physiotherapy to maybe a cortisone injection or even arthroscopy, but tonight we'll be concentrating on joint replacement. This is the case study for today. So she's a 60-year-old lady. She's had 12 months of constant shoulder pain and has had multiple cortisone injections in the past that initially worked, but are no longer working anymore for her. So when she comes in to see us, we're going to examine her first. And what we find is that there's a globally restricted range of motion, and she also has pretty exquisite glenohumeral tenderness. Now we're thinking, what could this be? You know, and luckily there are only really 2 things in the shoulder that can cause a globally restricted range of motion, and that's frozen shoulder or arthritis. So in terms of how to differentiate between these 2, age can be a factor. You know, in general, frozen shoulder only occurs in people in their 40s or 50s. So you can think about all those risk factors for people developing cholecystitis are also the same risk factors for people developing frozen shoulder. And like I said, arthritis is more in the older age group, but these things aren't, they're quite fluid, you know, so sometimes it's very difficult to differentiate between the 2 of them. And this is where investigations, as you know, are really important. So I do think that x-rays are really important for everybody. If someone comes in with these shoulder problems and they have an x-ray that shows florid arthritis, then our answer is there, it's really easy. But sometimes if the x-ray is normal, things aren't so easy. You know, ultrasound is not really that useful, as you know. It can show bursitis in almost everybody, which doesn't really help us very much. And similarly, CT scan is not very helpful either. So if we're a little bit confused, I think that MRI is the gold standard. MRI can show us patches of chondral damage that can be very painful, but not evident on an x-ray. And it can also show us if that person has adhesive capsulitis or not. So this is an x-ray of a shoulder, a normal one. And you can see there is a really wide space here in the glenohumeral joint for the articular surface. And there's also a really wide space here underneath the acromion where the rotator cuff tendons are going to traverse. And I guess most importantly, the center of the humeral head is aligned with the center of the glenoid. So this is a very well-balanced shoulder, a normal shoulder. If we compare that to what we see now on the right-hand side, this x-ray is very different. You know, there's loss of joint space, there's an osteophyte down the bottom, but importantly, that space between the humerus and the acromion is normal. So we can assume that perhaps the rotator cuff is intact, And so this is an X-ray of someone that has primary glenohumeral arthritis. These X-rays are a little bit different. So again, there's a normal one on the left, but now on the right, you can see not only is there loss of joint space in the glenohumeral joint, but there's also loss of joint space in the subacromial region. So this is significant because this patient has lost their rotator cuff many, many years ago. And now the center of the humeral head is high riding, it's above the center of the glenoid. So this shoulder is very unbalanced. And this is an example of rotator cuff arthropathy. Now it's really important to differentiate between primary glenohumeral arthritis and rotator cuff arthropathy because we treat them very, very differently, especially in terms of arthroplasty. So talking about shoulder replacement, in general, there are two different types. There's the conventional or the anatomical, which we can see here. This is where the humeral head is replaced by a metal or a ceramic humeral head, and the glenoid is resurfaced with a plastic component. So this is what you can see here in the middle and on the right-hand side. This is a really good joint replacement for decreasing pain and regaining range of motion. And in general, these patients have a really, really good range of motion, near normal even, and they enjoy a very good life afterwards. But it does mean that this patient has to have a rotator cuff to move the shoulder. Otherwise, it fails really early and doesn't work very well. This is where this type of shoulder replacement comes in. This is the reverse shoulder replacement. So instead of replacing the humeral head with a ball, what we're doing is replacing the humeral head with a socket. And the glenoid has become the ball or the glenosphere, which you can see here in the middle and on the right. So this is probably the most common type of shoulder replacement that we use nowadays in Australia. It's about a 2-to-1 ratio, reverse to anatomical. And it's very, very good for patients who have rotator cuff arthropathy because we're changing the mechanics of the shoulder. And the rotator cuff is no longer necessary to move the shoulder. And in fact, all we need is the deltoid muscle. Now, these are, again, very, very good for pain relief, but not as good as the anatomic shoulder replacement for range of motion. And we do sacrifice a little bit of range of motion, especially behind the back, in this shoulder replacement. In general, though, even though we are sacrificing a bit of range of motion, the patient ends up with more range than what they had before the operation. Just like what Nick was alluding to before, it's all about individualized planning nowadays. You know, we can't accept that everybody has the same shoulder replacement and does well. And I think that the most important thing nowadays is the preoperative planning so that we can figure out exactly where their shoulder replacement needs to go. So there are many types of ways that we can achieve this. And in general, it's all about computer navigation or variations of that. So what we do is we get a CT scan of the shoulder beforehand. And this allows us to look at the bony alignment of the shoulder and also to plan exactly the sizes and the position of the components that we want to place the shoulder in. This here is an example of GPS navigation. So the plan that we've had beforehand gets uploaded into a computer. There are trackers on the patient, on the coracoid process, and then all of the instruments have GPS trackers on them. And then this is what we see on the screen that you can see on the right-hand side whilst we're operating. So sometimes it even turns into almost like a computer game where you're lining up targets, matching up shapes on the screen, all to get the exact alignment that we want. And this is extremely accurate to within 1 degree. This is another example, patient-specific instrumentation. So this is very similar to what Nick showed with the knee, same idea with the shoulder, although it hasn't been around as long as with the knee. This is only about maybe 5 to 7 years old. The idea is that the same plan gets uploaded and sent overseas. So in this case, it's sent to a company in France. They produce a mold of the shoulder, which we can then sterilize and use as a guide with a bullseye so that we can figure out exactly where we want to implant the shoulder. And this is also accurate, but the problem is that it's expensive and it does require things to be shipped overseas. And there are a lot of human factors that can interfere with the timing of surgery sometimes. So this is the most exciting thing for me, really. Since about December, what we've been doing is doing mixed reality technology. So instead of sending that plan off to France, to make a mold, that plan gets uploaded directly into a headset, which we can wear at the time of the surgery. And the headset projects a hologram of our plan and of the patient's anatomy, which we can manipulate and overlay onto the patient at the time of the surgery and makes sure that we're really accurate to our plan. So it looks a little bit funny, but it's very useful. No matter how we do it, the idea really is just to get someone back to their chipping best. We want them to be back and enjoying life pain-free. Post-operatively, the idea is that patients are in a sling for between 4 to 6 weeks. They have to be warned that they can't drive for 6 weeks, and this can be a really important thing to organise preoperatively. There is not much restriction in terms of their range afterwards. Almost all patients can start doing an active range of motion straight away without any limitation in their range of motion if they have not had a subscapularis repair. But if they have had, then they do need to be limited for the first 3 weeks to protect that repair. Finally, these are some really common questions that I get asked about shoulder replacements all the time. And I think that we can really, make a team effort to figure all these out beforehand. So a lot of patients say to me, I've never heard of a shoulder replacement. Is it popular? Well, in 2020, we did about 65,000 knee replacements in Australia and only about 8,000 shoulder replacements in Australia. So it's definitely not as popular as the lower limb and joint replacements, but every year it shows the most growth of any of the other joint replacements. The next question is, are they any good? How long is it going to last? We have some really great long-term data that shows that shoulder replacements do as well, if not better than knee replacements, and they can last the same. So 95% survivorship at about 10 years. Patients like to know how long they're going to be in hospital for. In general, they're in hospital just over 1 or 2 nights, and most patients don't go to rehabilitation unless they don't have anyone at home to care for them or sort out their sling. Most patients are happy to go home after this time and get outpatient physiotherapy. Patients also like to know if they're going to get a good range of motion afterwards. And like we spoke about before, it really depends on the type of shoulder replacement that they get. The reverse shoulder replacement does sacrifice a little bit of range of motion compared to the anatomical, but both give very, very good pain relief, and the patient ends up with a better range than what they had preoperatively anyway. Can I swim or play golf or bowl? Yes, absolutely. There's no restriction in what you can do after having a shoulder replacement. And the idea is that we're getting people back to what they want to do. There was a great paper that came out of the States a few years ago that even showed that your driving range increases after having a shoulder replacement. And lastly, do we have to take antibiotics afterwards? I think that the orthopedic community is a little bit split in terms of this. There are some papers that show that we don't need to use prophylactic antibiotics in the setting of joint replacement and things like cystoscopy, colonoscopy, or dental procedures. But I would say that most orthopedic surgeons are a little bit OCD about infection. As you know, it is a disaster, having seen some of the pictures that Nick has shown. So I think that most of us would still really like to prescribe some prophylactic antibiotics. And that's my talk for today.
How do you see the altered reality evolving? You're a leader in this field. I think you've done one of the first ones in the country. Do you think it'll evolve into robotics as well, just like knees and hips have in the past?
Yeah, absolutely. So, the robot for the shoulder is on its way. It's probably going to be released in the States in 2027. So we're talking about 5 years. This mixed reality technology is going to be something that's going to be side by side. So as you know, Nick, there's always advantages and disadvantages to everything. And as you said before, that Maker robot is very expensive. It costs the hospital millions and millions of dollars. The advantage of this mixed reality is that it follows me around. And you're right, I was very lucky to do the first one in New South Wales. It's readily available, it's cheap, and it's accurate. And it is evolving right now. At the moment, it's not really a guidance system as so much as a visualization system, but it is going to be a fully fledged guidance system within the year. So I think it's going to be about parallel technology, using the headset as well as using the robot.
I agree. Look, for me, it's a no-brainer that a more precisely implanted prosthesis gives you better results, a happier patient, better recovery, less complications, and a better long-term result. And I think that's absolutely our goal as a department and as a hospital, to provide this to our patients and to our referrers?
Oh, absolutely. So it's all about choice. It's all about, the availability of technology to help us. I think the days that where we thought that we knew everything are definitely over. We know better than that now. So I'm looking at some Q&As here from one from Dr. Asawa. Patients like to delay surgery. How does one convince a better outcome with an anatomical replacement? I think the surgery that we perform is really a lifestyle operation, and someone is not ready for their shoulder replacement, be it in terms of their pain profile or psychologically, then I'm not really want to convince someone to have an operation. They need to, really just earn that joint replacement. They're sick of it. Their symptoms are poor enough that they want to undergo an operation. In terms of the outcomes, objectively speaking, it's true that anatomical shoulder replacements do give a better range of motion than the reverse shoulder replacements, but I wouldn't say that their outcome is any better. I think that their range of motion, although objectively poor, or poorer, I should say, still gives them a very, very good functional life. So I wouldn't be too concerned about whether to go for an anatomical versus a reverse. Dr. K?
Tim, I was going to chime in there and say, look, that's a fantastic question because, we never pressure patients into having surgery like yourself, where we will try cortisone injections, we'll try hyaluronic acid injections, physiotherapy, anti-inflammatories. And it's all about quality of life, as you say. And I often say to my patients, when it starts affecting quality of your life, when you can't do the things you want to do, you can't take the dog for a walk, you can't play golf, you can't go walking with your friends, you can't go hiking, then it's time to intervene. But ultimately, it is your decision. That's why it's called elective surgery. You elect to have this done when you want to have it done.
Absolutely, Nick. Yeah, well said. Dr. K has written, my patient was told he could not lift more than 5 to 10 kilograms after shoulder replacements. No, I don't impose those weight limits on my patients. The only thing they can't do is contact sports. An anonymous has written, can someone manage the post-op course if they live alone? Yes, they can. So that's the advantage of having a shoulder replacement, is that they can actively move their shoulder straight away. So sometimes it is a little bit difficult getting in and out of the sling, but the physiotherapists teach them how to do that on their own. And in terms of self-care, when they are at home on their own, they can shower on their own by using gravity and their body to lean one way or the other so that they can clean their arm. So it is very manageable.
That was the last question. So if there's no other questions, I would like to thank Dr. Yeo and all the other speakers that we've had tonight. Thank you, great presentations, and enjoy the rest of your night, everybody.